Leon was, I believe, the first postdoctoral fellow of Stu Kaufman, who many of us know. So he has a fine pedigree. Leon is also a fellow of the Canadian Royal Society, which is the Canadian equivalent of being a member of the National Academy. So he's a very eminent guy, and with that, I think I will pass over to Leon to entertain us. Now, Leon's going to give a regular talk for 60 minutes or how things go, and then we'll have a period of questions thereafter. This is being taped, so please don't do anything embarrassing or actionable. If you can. And for that, I'll hand over to you.
So thank you very much. I very much appreciate the invitation. When I was a little boy, our family used to live in Brooklyn, New York, and every summer my parents were school teachers in the public schools in New York City. We would take a train from Grand Central Station in New York City and end up in Milton, Vermont, in the Vermont Central Train Company, which probably doesn't exist anymore. And there was a little bungalow colony on the shores of Lake Champlain near a place called Eagle Mountain, which is about 7 or 8 miles from Milton, where we had ice boxes. So I was just thinking, in the wintertime, back in those days they had kerosene stoves and ice boxes, and they would cut the ice from the lake, and that would keep your food warm, cold in the wintertime, in the summertime. So it would keep you cold. They cut it in the winter, and it kept your food cool in the summer. So it's a pleasure to be back, and I've had an exciting day meeting many of the really interesting people here and learning about the work that you're doing. So the title of the talk is Predicting the Risk for Sudden Cardiac Death. This is not something that I know how to do, but it's something that I think people can do a better job doing, especially if there's more collaboration between people who have expertise in some of the mathematics and physics and computer science questions and some of the medical questions. Whoops. Okay, so I do have a research contract and patents with Medtronic device manufacturer. The basic idea of the talk is summarized here. Sudden arrhythmic cardiac death is associated with complex dynamics in a nonlinear biological system. So that system is the heart. I believe that if we understand the mechanisms of the rhythms, we should be able to better diagnose and treat them better. And I also believe that mathematical analysis of mechanisms of cardiac arrhythmias in individuals should lead to the better development of better understanding of fatal cardiac rhythms, and it should be able to improve patient care. Now, I have to say that I think that there have been huge strides in care of cardiac problems, and I have to say that to the best of my understanding, none of that advance has come about as a result of understanding the nonlinear dynamics of the heart. Okay? It's largely come about as a consequence of very, very smart and talented physicians working with a variety of sometimes basic scientists and understanding certain basic things, for example, about fat metabolism, also working with device manufacturers and perhaps some drug manufacturers. So certainly there has been improvement of cardiac health, but I don't believe that to date it's really been due to the sorts of things I'm about to spend the next hour telling you about. Okay, so the outline of the talk is I'm going to, so to the best of my understanding, there's one cardiologist here, is that right? Is there two? One? At least two. Who's the other one? Okay. Okay, so at least two. And one medical student, MD, PhD student? Any more medical students? Residents? Any cardiology residents? No. Okay, so the beginning is to get the nonlinear dynamics people to teach them all they need to know about cardiac in 4 slides. I'm going to then address the problem of sudden cardiac death. I'm going to give some information about a style of doing clinical trials associated with treatment. Most of the talk will talk about experiments and mathematical analysis of arrhythmias in people and in model systems. And then I will finish up by talking about what can be done or hopefully might be done towards better risk stratification. Okay, so this is the schematic picture of the heart. Why is this not showing? Oh, there. Okay, so this is the pacemaker of the heart. It's a part of the heart tissue. It generates waves that go across the atria of the heart, through the AV node of the heart, and down into the ventricles. Okay? So this is the basic sequence. This is a spontaneous pacemaker, but its frequency is modified by the nerves that are in the vicinity of the heart and circulating hormones. This is a schematic picture of the cardiac cycle as measured on an electrocardiogram. These different bumps and complexes, which we'll be talking about a little bit today, have names: the P wave, the QRS complex, and the T wave. The P wave is associated with the time when the excitation is traveling over the upper chambers of the heart, the atria. The QRS complex is associated with the rapid contraction of the ventricles. People say depolarization of the ventricles. And the T wave is associated with the recharging of the ventricles, the repolarization of the ventricles, getting ready for the next cardiac cycle. And of course, associated with the electrical activity measured by the electrocardiogram. Electrocardiogram is nothing more than measure potential differences on the surface of the body. There's also the mechanical pumping action, which is measured by the arterial pressure, and which everybody can experience for themselves just by feeling the pulse in their wrist or in their necks. Now, this is an actual electrocardiogram. This is these boxes are 200 milliseconds in a standard paper speed, so 5 of them make up 1 second. And these funny-shaped complexes are called premature ventricular complexes. They come from the ventricles, and they occur sometimes. Most people will have them sometimes. Sometimes people have them a lot. The significance is not, if you know that you have them, you should not be worried because of what I'm about to say. But it's extremely common. Notice that the time from here to there is approximately twice the time from there to there. So this is the normal frequency of the heart, the normal period of the heartbeat, and this is about twice. So this comes from the ventricles, and then the next normal beat is blocked in its propagation through the heart. Now, these are now very abnormal rhythms. This is a rhythm called ventricular tachycardia. These complexes are coming from the ventricles, and this is quite a rapid rhythm, a little bit less than 300 beats per minute, and it's quite regular. In this case, a rhythm like this will be certainly very dangerous, and in some cases can lead to fatality. And this is ventricular fibrillation. This is a picture of the terminal rhythm of the heart. So this rhythm like this would always be fatal unless treated in very rapid order. Okay? Now, this is what, picture of Peter Spector. This is what he does for a living. He's sticking, it's not Peter, right? But he's sticking a catheter in the groin of somebody, inching it up into the heart, trying to also give ablations, trying to do recordings in order for certain types of dangerous rhythms. By destroying certain parts of the heart, he is able to cure the patient and and eliminate the cause for the rhythm. So that can be done by either freezing or by burning given regions of the heart. So the trick is to understand which parts of the heart to destroy and which not to destroy. Why might this work at all? By destroying part of the heart. One of the concepts of cardiac arrhythmias is that many serious arrhythmias are associated with excitation traveling around in a circuit, so that the period of the oscillation is not set by a pacemaker as it is in the normal heart, but it's set by the time that it takes excitation to go through some type of circuitous pathway. So what the task of the cardiac electrophysiologist, or one of the tasks, is to try to identify a place where they might be able to burn or destroy, which would cure the arrhythmia. For example, if this is some part of the heart, if they could burn some region of the heart which would block this circuit, then they would be able to cure that person of this mechanism of arrhythmia. Okay? So this is just a picture from a group from Mark Josephson, and Mark was someone who was a cardiac electrophysiologist, and I spent a year's sabbatical with his group back in the 1990s. Okay, so what's the basic problem? Okay. So this is an electrocardiogram that's taken from the PhysioNet website. This is a website that's organized principally by Ari Goldberger in Boston, as well as colleagues at MIT, which has data, large amounts of physiologic data of different sorts available. There's a set of data that has records of patients who died while their heartbeats were being recorded. So this is an example of electrocardiogram from an 82-year-old woman. Here at about 3:42 in the afternoon is a normal sinus rhythm. So this is the normal beats of the heart, and here is a premature ventricular complex. Then a little while later, there's another premature ventricular complex. At about 4 in the afternoon, there was the normal beat, and then there's a premature ventricular complex, there's another normal beat, and there's an alternation between the normal beats and the premature ventricular complexes. Here there's a sequence of several of these premature ventricular complexes, which is now called non-sustained ventricular tachycardia. Ventricular tachycardia, we mentioned that before, tachycardia going too fast from the ventricle. It's non-sustained, it stops. So you can learn some terminology. Say, oh, well, there's non-sustained ventricular tachycardia. That sounds good. Okay, notice how it comes. Here's this, here's that. It's going in some kind of repetitive, interesting pattern, but then nothing particular happens. But about an hour later, there's a normal beat, there's premature ventricular complex, there's non-sustained ventricular tachycardia that looks very similar to what you saw before, but it lasts a little longer. There's one normal beat, and then the patient dies. Okay? Now, the question that I'm interested in is, why did this 82-year-old woman die at this particular time in her life and not earlier, or not at any other time in the preceding 82 years of her life? I also don't know what is actually happening inside her heart at the variety of times, or whether, if we had measured her electrocardiogram at 3:42 in the afternoon, whether or not you would be able to say, whoa, that person is at a high risk of sudden death. So I think that there is nobody at the moment who's able to say this. But this is the question that fascinates me. Also, as someone who's interested in dynamics, I have to believe that these abnormal beats that are occurring over here and over here and over there have something to do, some mechanistic connection with what happens when the patient eventually dies. Okay, so this is a slide from a cardiologist named Meyer Berg, And it's gone to point out that cardiologists, there's been a huge effort, which I'll just give you a little bit of a feeling for, in trying to predict the risk of sudden cardiac death. And this slide is to emphasize the fact that patients who are identified as having comparatively low risk of sudden cardiac death, actually that aggregate number of people with low year compared to people who have high risk of sudden cardiac death that have comparatively low number of events per year. The incidence, the frequency of the deaths is much higher in those with high risk, but because it's a comparatively small number of people, it's still of the incidence, according to analysis, is happening in people with either low or not very well understood or identified risk factors. Okay. This is an example of an implantable cardioverted defibrillator. It's a device that can be placed under the skin. It can be attached to the heart. And if there's an arrhythmia, such as ventricular tachycardia or ventricular fibrillation, this is reasonably successful in detecting that arrhythmia, giving a shock to the heart, and restoring the sinus rhythm. Everybody who has a television, who's watched medical shows, have always seen them putting the paddles on the person's chest, saying, stand clear, then there's a jolt, and then they, tick, tick, tick. Everybody smiles, okay, it's okay. So this is doing the same thing, but it's inserted into the patient's body. Obviously, if the patient is about to die because the quality of their ventricle is very poor, it doesn't pump blood very well, they have serious heart disease, this will not necessarily prolong life at all. But many people with relatively critical tests end up dying, or no reason to know that they're not healthy, would end up dying from an arrhythmia that could be terminated by this sort of device. There's good reason to have better ways, good reason from the point of view of the individual. If you're someone who might be susceptible to sudden cardiac death and your life could be saved by this, you would want to have it. If you're the company that makes these, like Medtronic, you would like people to get it. If you're the guy who's paying the bill, like the US government, you would like it to be used wisely, okay? Because it's very expensive to put them in. Okay, so this is, so one of the most famous people, I'll just read this, Cheney's change-out. Vice President Dick Cheney's implantable cardioverted defibrillator was replaced Saturday at George Washington University Hospital. News outlets reported. There were no complications, and the vice president emerged from the hospital about 4 hours after he entered, according to the reports. The procedure had been scheduled after a check of the device during the vice president's, this was from 2007, annual physical last month showed that the battery was nearing the end of its lifetime. The device was implanted in 2001, and according to the vice president's office, which we know we can always believe completely, on no occasion did it deliver a shock. Okay? So this had been sitting in his body for 6 years, according to this report, and had not been actually needed because it hadn't been activated. Okay, then it says, Cheney's cardiovascular health history is one of the world's most publicly documented, as reported over the years. It includes 4 heart attacks before he became vice president, coronary artery bypass operation, 2 percutaneous interventions, and an episode of deep venous thrombosis on a recent international tour. So he might be high on people's list of somebody who might need a device such as this, but in fact it wasn't used. Okay? And then this is something I just downloaded from the internet when I was trying to see the cost of the implantable cardioverter. Last year when I was in the hospital, I was told it would cost $30,000 for the ICD and the procedure. We lost count at $100,000. For the complete hospitalization, I am thankful I was able to pay my insurance premiums. Okay? So I don't know how much it costs in Vermont in this hospital, but they're expensive devices, they're expensive procedures, and there can be complications. So you don't want the device to be in patients that don't necessarily need them. You'd like them to be in patients who could potentially benefit. So this is This is the definition of what the problem is. So this is an example of a strategy for clinical, discussion of a clinical trial. So this is, I showed you an example in which there were premature ventricular complexes prior to the patient's dying. Examples like this are not uncommon. Probably all cardiologists have seen examples such as that. So there was a hypothesis many years back that extraventricular beats, these PVCs, premature ventricular complexes, appear to be dangerous. So I showed an example. So that you say, find a drug that reduces those, and you can make a hypothesis. Giving the drug to people at risk of sudden cardiac death will reduce the number of sudden cardiac deaths. Okay? So the drug is documented to reduce the number of premature ventricular complexes. And then you do how do you determine if that hypothesis is correct? Well, you take 1,500 people, you give 750 of the people the drug, and the other 750 people you treat as you would normally. These are all, in this particular example, these are all patients who have had a heart attack and have lots of premature ventricular complexes. This is the cardiac arrhythmias suppression trial going back to around 1989 or 1990. This line is the patients that took placebo, took sugar pills, and this is the line that patients who took the drug, this is the percent alive after about a year and a half. There were approximately 50 to 70 extra deaths in the arm that was taking the drug. That is, the hypothesis was disproved. Okay? So I have a thing about hypotheses because I've lost more grants because they said it didn't have a clear hypothesis. So one of the sine qua nons in medical applications is you have to have a clear hypothesis stated. So this had a clear hypothesis, but anyway, they disproved it. Okay, so what I'd like to do is spend some amount of time talking about model systems. So I believe that most of the work that we do has done with analysis of dynamics in model systems, and I hope that you'll be able to see the connection with the types of rhythms that we've just been talking about in people. And most of our work is done in chicken hearts or in pieces of chicken hearts. And I would also like to thank my colleague Alvin Schreier. So I've collaborated with him. It's in his laboratory that the experiments have been largely done. And it's been a great honor and privilege to have the opportunity as someone who's interested in the mathematics to collaborate with people who are doing these experiments. Okay, so one of the experimental systems that we use are these little balls, aggregates of heart cells. So this is about 1/10 of a millimeter in diameter. They beat spontaneously. These are constructed from the hearts of chickens. The hearts are dissociated, or parts of the heart are dissociated. They're allowed to reassociate, and each of these are going to beat spontaneously with their own intrinsic rhythm. They can be studied in a variety of ways. The initial way was to take a glass microelectrode and insert these in the cells, and then through those glass microelectrodes, you're able to do recordings of the activity, and you can also give electrical stimulation. So I'm just going to show one slide. So Jason mentioned chaos in the introduction. So one of the early studies that we did was studied the effects of single as well as periodic delivered to these spontaneous. There were a very extensive series of experiments carried out by Michael Berg, who's a McGill and then was a student at McGill, in which we tried to study the effects of stimuli to the heart at different amplitudes of current and different phases in the cycle, and also study the effects of periodic stimuli at different amplitudes and different, and quite a understanding of that, and I just want to show this one. would claim shows chaotic dynamics in the heart of pieces of bumps the act. The dynamics. Over a paper. And we had this, so this was actually, we ran it. Yeah, that's it? Yeah, it's really exciting. Cardiologists in California, in Southern California, we won't mention any names, with their white coats in front of an electrocardiogram of a dying patient and say, yes, well, this is chaos in the patient's heart, and so they showed the cardiologists and saying we were on the cutting room floor. Okay, so here's an experiment now. Here's a systematic experiment in which here is spontaneous beats. Spontaneous beats. Here's a sequence of stimuli that are given. Here's 4 stimuli that are given. And then just stimuli, and then we let the heart beat. Here's the last, and here's the beating afterwards. So is it clear what's happening? That as a result of that stimulation, the heart rhythm is being slowed down. This is stimulating it and training it in a one-to-one fashion at a rate that's faster than its intrinsic rate. Okay? That's what the experiment is, and that's measuring this. So we thought of doing an experiment, and the experiment is to now take this activity, put it into a delay line, and then give a stimulation after a fixed delay after we record the contraction. After we record this action potential, we wait a certain length of time, and then we give another stimulus. In other words, going back to that cardiological idea of a reentrant circuit in which the frequency is not set by the pacemaker itself, but is set by some pathway that the excitation has to go in, we're essentially engineering that, where part of that loop is now this electronic circuit which has been added. And when we do this, we get this types of data. Let's just look down here. When the delay is 360 milliseconds, here we can say this is a spontaneous beat. Then 360 milliseconds after that spontaneous beat, we give a stimulus. The stimulus gives rise to an immediate action potential, another once the pacemaker starts again, gives another beat. These bursts of paroxysmal of activity, continuously starting and stopping, just based on the physiology, the intrinsic physiology of the heart cells and the geometry of this reentrant circuit. Okay? These are experiments that were done, once again, in Troyer's laboratory by a graduate student named Arkady Kunish. So we find that a potential mechanism. I like it because behavior looks to me like the sorts of behavior that we can see in intact patients' hearts sometimes these bursts of activity, which non-sustaining ventricular tachycardia, which stop, but in that context, we don't necessarily understand what the mechanism is. So since things in the heart are happening in space, we said to go. Status is to monitor the spatiotemporal patterns of excitation by videotaping the spread of excitation, and you can monitor the spread by seeing calcium. During the contraction phase, there's a lot of cellular calcium. There are dyes that are sensitive to, that have differential fluorescence as a function of the concentration of calcium. So by monitoring the excitation from these calcium-sensitive dyes, it's possible to monitor the spread of excitation. So one of the experiments that was done was to take the tissue and to very much, these types of experiments are very much motivated of a ring of excitation as being underlying factor. So these are experiments that were done by a visiting professor from Mexico, Hortensia Gonzalez, along with postdoctoral fellow Yoshihiko Nagai and others. Okay, so when we have this, in this particular instance, we have a pacemaker over here at approximately 4 o'clock, sends off waves, they zip around and they collide on the opposite end, the opposite side, the antipode of the ring. This ring, by the way, is just about 8 millimeters in diameter, external diameter, 6 millimeters in internal diameter. So it's approximately a 1 millimeter wide ring. It's a rather narrow ring. Okay? We can also have situation in which the excitation keeps on re-entering around the ring, going around exactly like we anticipated before. And then finally, we can have much more complicated situation in which here we see this, oops, by the way, so you'll get a couple of chances to see it. Here we have a pacemaker at about 12 o'clock. It's about to start again, I hope. Let's see. You can't tell when it starts. There's pacemaker, sending off waves. They go around. Now it goes around. Now it goes around. That keeps on going around, but that will eventually block. You have the wave zipping around, and you have the pacemaker there, and they're leading to rather complicated dynamics interacting as a result of the geometry of the ring, the pacemaker, and blockage, heterogeneities in the ring that are leading to blockage of the excitation. We can try to model this using equations. For non-mathematicians, excuse the equations, I won't say much about them. The type of equations called Fitzhugh-Nagumo equations. They're model equations for excitable tissue like the heart. And in this model, we can model a ring. The data, the simulation is shown at the bottom. I don't know if people can see this from where you're sitting, but there's a pacemaker over here. There's another pacemaker over here someplace, and they have slightly different physiological properties. Now, initially, this pacemaker sends off waves. This is a ring, so there's cyclic boundary conditions, right? The wave comes here. At one point along the way, the wave got blocked going in one direction, but came back around in the other direction, so that as a result of the physiological properties, just in this completely mathematical system, the symmetry of the waves coming and breaking on the opposite side of the ring was broken, and we ended up with the wave going around the ring. That wave would eventually block, and the pacemaker would take over again. So just by putting together very simple properties of pacemakers, heterogeneities, waves, and conduction, it's possible to observe this complicated dynamics of spontaneous starting and stopping. Okay. Many people know about spiral waves in cardiac tissue. There were original theoretical predictions for the existence of spiral waves by Norbert Wiener, who is one of the founders of cybernetic theory. People are probably familiar with the name. working with a physiologist known as Isadore Rosenfeld, also Russian biophysicists, Valentin Krinsky, Art Winfrey, and several other people. So there are initially theoretical predictions, and then subsequently there was some experimental observations from the laboratory of Halife, Frank Rutkowski, and many others. Okay? Now, after Gil Bub built this apparatus to view the spread of the cardiac excitation, he was working at a rather low resolution, and what he saw were these bursts of activity. This is now measuring fluorescence from heart cells, chick heart cells, cultured in 2 dimensions, and he would see bursts of activity, but he couldn't resolve those bursts. When he was able to resolve the bursts, he found very remarkable behavior, and the remarkable behavior was associated with the spontaneous initiation of rotating spiral waves, which would spontaneously start and would spontaneously stop. So at the end of this will basically die out, and then he cut off taping, but it would be quiescent for quite a while, and then it would start again. So there would be, once again, this paroxysmal starting and stopping of these spiral waves that were taking place here. He could also build systems in which he changed the density of the cells and also added a compound which would block and make the conduction from cells to cells not as efficacious as it was before. And what happens is when he has very healthy tissue, high density, and no drug, he would basically get pacemakers acting similar to what we imagine is happening in the intact heart. As you have lower density of cells, more heterogeneities, and more blocking agent, you get very, very irregular behavior. You get initiation of spontaneous bursting patterns like we just described, and then you get these very low voltage signals, very weak signals propagating in irregular ways, which we imagine is similar to the types of behavior that's occurring in hearts, in human hearts when they're undergoing fibrillation, like I illustrated earlier in the talk. Now, how can we generate mathematical models that have these types of behaviors? Well, the basic idea of the mathematical model that we have is to try to make very simple models that capture the key features of the heart. So what do we mean when we say simple models? In our context, the cells have to be excitable. What does that mean? If there's some excitation coming into them, then that excitation can spread from cell to cell. There are some spontaneous pacemakers. Some of the cells can initiate waves on their own without being excited. That has the same property that we will call fatigue or overdrive suppression that I illustrated before, and that is that if a cell is rapidly excited, it becomes less excitable as time goes on. It's less spontaneously active or will conduct not as briskly as before, and there's also heterogeneity of tissue. So not all connections are the same in all directions. When you just take these basic properties and put them together, then depending on the particular parameters that you have, you can have situations which correspond to very well coupled tissue, high density, in which pacemakers will start and the waves will propagate across the field in the kind of fashion here, just having waves, target patterns coming from particular points in space. But when there's lower density, you can initially get waves that start, but then those waves will break up, they will turn into spirals, those spirals will continue, and those spirals will eventually die out. So once again, we can have this type of paroxysmal rhythm in which there's an initiation of some rapid rhythm, which will eventually put itself out and then this can continue indefinitely. So we have this types of spontaneous paroxysmal types of rhythm. And we can also look and see the organization as we vary the amount of fatigue and we vary the amount of coupling. When there's very strong coupling, we get target patterns, we get these bullseye patterns. When there's very weak coupling, we get block. And then when there's intermediate levels of coupling, we can either get spirals or bursts of activity, depending on the extent to which there is the fatigue component of the cells as a function of the rapid excitation. Okay, so this is these theoretical. These are these experiments. Very recently, we've been working, and when I say very recently, on the last three or 4 years or so, we've been looking at the effects of blockage of potassium channels in hearts. Potassium channels are very important in the repolarization, the recharging of the hearts, and it's also known that there are many cardiac arrhythmias that are either associated with drugs, which might block potassium channels, or genetic abnormalities, so that the potassium channels themselves have abnormalities. So in these experiments, there's a drug that's blocking a particular type of potassium channel called the RKR channel. The drug is called E4031. And this is from a paper a couple of years ago, a few years ago, in which this is now in aggregates in which they're initially beating quite regularly. Then the drug is added, and after the drug is added, it goes through an evolution of rather complicated rhythms. Here are rhythms in which there's doublets of activity. Here there are bursts of activity. And here these bursts of activity can occur in quite irregular rhythms. Eventually, at long times, there's a much faster rhythm that prevails. So this is a sequence of changes of dynamics, or in nonlinear dynamics jargon, bifurcations that are occurring subsequent to the addition of this drug added to the aggregates. It's possible to develop mathematical models of the activity of the cells, and the mathematical models can show quite similar dynamics to that which is observed under the blockage of this particular potassium channel. So this is now a theoretical slide done by a current graduate student at McGill, Thomas Quayle, giving very similar rhythms to what is observed. Normally, of course, these models that are being used, the ionic models, are very complicated, and of course it's very hard to say that these models are really the correct model of what's really happening. It's also possible to grow the cells in tissue culture in 2 dimensions as before. This is work now that is not yet published from Bart Borek. No, that's okay. You can keep going here. Here there's a pacemaker. There's pacemaker. He built these tissues to have a pacemaker at one point in the cell. After addition of the E4031, the waves come out. They go over the pacemakers. They can interfere with the pacemakers. And then it appears as though, as a consequence of this pacemaker, which is being driven at a more rapid rate by a different pacemaker induced by the drug, the waves coming out and lead to these reentrant waves once again, similar to the same sorts of spiral waves that we've seen before. So this is experimental data. And then once again looking at ionic models. No, sorry, this is not an ionic model. Now this is a simplified model. Very similar types of behavior is observed in these simplified models. So this is work. This is work which is now undergoing, trying to understand mechanisms that can give rise to abnormal arrhythmias under the compromise of the potassium channels in the heart. Okay, now I would like to go back and finish up with several slides which try to bring this back to the practical problem facing cardiologists, and it's to better assess the risk for sudden cardiac death. Analysis of arrhythmias in people. How do cardiologists do risk stratification for sudden cardiac death? I would say one possibility is to analyze mechanisms of arrhythmia in individual patients, and I'm saying, I don't know if the cardiologists would agree with me, that this is not always done. The quality of the ventricular function is assessed. The presence of previous arrhythmias, if the patient has suffered a cardiac arrest, they would be definitely a good candidate for an implantation, and so forth. So this is a major problem in cardiology now. Now, I think that I have this as a mystery tracing. So one of the things that I loved about cardiology is that when you go to the rounds, the head of the group presents electrocardiograms which the residents or fellows or students or other cardiologists are supposed to interpret. And, of course, the leader gets his opportunity to show that he's quite knowledgeable by giving the interpretation if other people have failed. So this is an electrocardiogram from a 15-year-old boy who fainted in the cafeteria. He had had an atrial septal defect that was surgically corrected at 6 years of age. This was an electrocardiogram that was sent to me in records from David Gordon and Daniel Scagliotti. David Gordon was a theoretical physicist who's actually a friend of a famous nonlinear dynamicist named Mitch Feigenbaum, who decided to go into cardiology, pediatric cardiology in Illinois. So the question is, what is the rhythm, and does it convey a higher risk for sudden cardiac death, for sudden death? And I have to ask a cardiologist to give an opinion about this. Would one cardiologist like to give an interpretation? See, this is putting them on the spot that they always put other people on in their teaching.
Say, I don't know.
I don't either. But I can tell you that the rhythm is sinus rhythm. That there
Okay,
is,
so just explain that to the people.
So there are P waves before most of the QRSs, which denotes that the atrium is driving the ventricle for most of these beats.
Right.
So, but what's interesting about it is the way that the ventricle is activating. That's the interesting thing. So the ventricle, remember, is the big, there's the little guys, the P wave, and the big thing that comes after the little guys, the QRS. And if you look at each of these QRSs, they change. So the one that you're on right there is wide. The second one is wide, and then all of a sudden it's narrow. And what's interesting about that is that there's a delay from the atrium to the ventricle, allowing the His-Purkinje system, which is the wiring into the ventricle, to sort of repair itself so that it can conduct relatively normally for that beat. Okay? So there is rate-dependent variation in how well the conduction system is behaving in this patient. So that's concerning. And on top of that, the patient is having frequent PVCs. So you were just showing that red dot there is a ventricular beat. That's premature. And so I would say with the history that you're giving, that this is a kid who fainted and has these abnormalities, that yes, there's something to be concerned about.
Okay. So So would you like to add anything else? Would you give the name to the rhythm?
Well, the rhythm is sinus rhythm.
Yeah.
With frequent PVCs and intermittent aberrant conduction.
Okay. Any other notable features on
this?
Yes.
So the T wave, the T wave varies in amplitude.
Yeah.
So there's.
Okay. Any other notable features? Sorry, I don't. We have to move. I have to get to the end of the talk, but.
Are you implying that the QT, well, the QT when it's aberrant is very long, but you'd expect that. So
yeah, there's another notable feature here. Okay, so that's good. So I can tell the cardiologist something that they don't necessarily know, and but that's okay. Another very notable feature here is that the coupling interval of the PVC to the preceding normal beat is quite variable in this. And the actual interpretation of this record is that there are two pacemakers. One is the sinus pacemaker that has a regular rhythm. Another is a pacemaker in the ventricles, the ectopic pacemaker, that has a regular rhythm. If the ectopic interval falls outside of the refractory period of the sinus rhythm, then you see this extra beat. If it falls during the refractory period of the sinus rhythm, you don't see this extra beat. And if they fall at approximately the same time, then you see what's called a fusion beat. So you notice the different morphology. But my interpretation of that is different than your interpretation of that. And this tracks through the entire set of the records. So you can do this over a much longer strip than we have here. So you can just be a mathematician, and I think I can convince you that this is the underlying mechanism of what's happening in this particular patient. Now, one of the things that we can do in this that I like to do is to count the number of normal beats between two abnormal beats. So in this particular record, there are three numbers, 1, 2, 3, 4. I'll count this as a normal beat. Here there are 2, and here there's 1. So in this record, there are 3 different integers of the number of normal beats between abnormal beats. Okay, and there's the mechanism. So do you accept this as a mechanism? This mechanism is called parasystole in classical cardiology literature. Go back to Shamroth or Langendorf and Pick and so forth. Okay? So this is what I call the rules of pure parasystole. So I'm now going to count the sequence. I have a mechanism of this rhythm. I'm going to count the numbers of normal beats between abnormal beats. I'm going to generate a sequence of integers. Okay, in that preceding slide, the sequence of integers was 4, 2, and 1. So now I can do mathematics and prove a theorem, and the theorem says that given this mechanism, then count the sequence of integers that you have, assume that the sinus rate and the ectopic rate are both constant in time, and that the refractory period is constant in time. I can generate the sequence of integers, and in the sequence of integers, I have 3 rules. One is that there are 3 integers. 4, 2, and 1 are 3 integers. Second rule is one of those is odd. 1 is an odd integer, 4 and 2 are even integers. And the third rule is the sum of the 2 smaller ones is 1 less than the larger one. So 1 plus 2 is equal to 3, which is 1 less than 4. More than that, if you measure, which you can do from these records, you can measure the ectopic and ventricular cycle length, make estimates of the refractory time in those cycle lengths, and you can come up with a plot, and in that plot, given any ratio between the ectopic and sinus cycle length, and given any ratio of refractory time to sinus cycle length, I have different regions of parameter space. In each one of those regions, I have these 3 triplets, so I can tell you what those triplets will be based on this mechanism. So we were extremely excited when we discovered this back in the 1980s, and I was invited to give a talk in San Francisco. A famous cardiac electrophysiologist invited me. Also grew up in Brooklyn. Took me out to a great restaurant the night before, and I showed this, I described this, and he got really angry. And he said, this is nothing more than mental masturbation. So my response is, well, we all have to get it off in our own way. But the thing is, from a point of view of a cardiologist, there's no way in which knowing this will help them to be able to do their job. Because what's really necessary is to know whether there's any risk associated with it, and if there is, what can you do either to correct the risk factor or to institute a therapy. Okay, so we were working on developing methods. So I'm just going to zip through the last few slides. Now we started working back when I was on sabbatical in Boston. methods which tried to give a depiction of some of the complicated rhythms that can occur over the course of very long records. And essentially, these are two-dimensional histograms in which let's just look over here. This is the number of sinus beats between two of those premature ventricular complexes. And as different sinus rate levels, as the rate, the basic frequency of the heart changes in this particular patient, we see different patterns of these rhythms, all of which are consistent with mathematical models. Also, notably in parasystole, there's long fluctuations, long differences, big differences in the coupling interval of that abnormal beat from the preceding normal beat. Okay? This is now from a patient who had sudden cardiac death in the PhysioNet database. In this record, there's a completely different type of dynamics in the arrhythmia. Now there's principally one sinus beat between ectopic beats, very similar to the sorts of records we saw in that initial lady that died from the sudden cardiac, died from that arrhythmia. And the coupling interval here was also quite fixed. Interestingly, there is a colony of German shepherd dogs that are prone to sudden cardiac death. This is now a slide from Sidney Moise and Robert Gilmore in Cornell, in which these dogs have frequent premature ventricular complexes, also have frequent non-sustained ventricular tachycardia, and also are susceptible to sudden cardiac death. In these dogs, if you look at the heart print from one of them, it looked very, very similar to the records that were present in that previous slide. So this is work that was done with Claudia Lerma, who did a postdoc in McGill and is now a faculty person back in Mexico. Now, we have recently been collaborating with a cardiologist named Hukuri in Finland. He has a trial which is called the Charisma trial. I forget what that acronym stands for, but they're trying to do measurements of risk predictors, factors that people have taken for risk prediction of fatal or near fatal cardiac arrhythmia with patients who have had a heart attack and have impaired ventricular function. So with this variety of factors, they have what's called the hazard ratio. What's the increased probability that a patient with one of these many factors, so there are about 15 factors here, some of them related to the amounts of fluctuation in the normal beat, some of them related to the whether or not the cardiologist can induce rapid heartbeats by giving stimuli, some of them related to looking at just the records for the heartbeat. So there are a variety of factors that they have. The increased hazard ratio can only go up to approximately 4 or 5 or 6 or 7 in this particular data set. So if you could, we could just, okay. So in conclusion, I'd like to say that excitable cardiac, we also have neural tissue. We could have included neural tissue, but I didn't in this, can generate complex rhythms. There's theoretical understanding of these rhythms in many model experiments and equations. Similar rhythms can be generated by different mechanisms. I haven't given many examples of that in the talk, but we can have different mechanisms that give rise to quite similar behaviors that you might measure at a very crude scale on a surface electrocardiogram. I believe that there's a real need to study and understand complex rhythms in individual patients, and I believe this is something which, if I can't guarantee that it will be useful from a medical point of view, but from a pure intellectual challenge, people's hearts can generate very complicated rhythms that we're still not very able to understand, or to understand the mechanisms or the significance. So in conclusion, I've tried to mention several of my collaborators as I've gone along. I'm greatly indebted to the opportunity to work with them and also to the variety sources of funding. So thanks very much.
Thanks for your talk, Leon. So you showed some example simple models that demonstrated the type of dynamics that are observed in the heart. I'm wondering if there are any very sophisticated three-dimensional finite element type simulations of the heart that do as well simulating the type of behavior that you observe.
Okay. So at the moment, there's very significant efforts at doing what I would call whole heart modeling, which are three-dimensional models which will reproduce some or many aspects of cardiac physiology, both normal and abnormal physiology. I think that there's belief among many people that we should be able to develop these models to the state where we will be able to understand the mechanisms of the arrhythmias based on doing certain measurements like MRI and so forth. We can learn a lot about the anatomy of the heart. Now, there are definitely efforts of doing it. The big group in Australia, Peter Hunter's group, Auckland, of course, yes, of course. Sorry about that. Big group in, there's Yoram Rudy, who has a big group in St. Louis. So there are significant efforts that of people who are doing this now, and there are other people in addition who are doing this. To what extent, to what extent is what's happening at what's the space scale of what's happening and what's the abnormality of the physiology? It seems to me that there's a level between the detail. My style, a lot of the work that's being done along those lines is done very much by engineering types of people rather than physicist people. So physicist people are often trying to look at the universal bifurcations that are happening in the models in rather crude models. There's this other group that's trying to do detailed, anatomically, physiologically realistic models. There's still, I believe, a reasonably big gap between both of these, but both groups are working towards each other. So I think that there's a lot of optimism among some people that it will be possible to have realistic models which will have diagnostic, maybe even therapeutic significance.
And one other question is, does the PhysioBank have records for people who are healthy and have survived? And I'm wondering if, I'm imagining the cell phones that are in our pockets, I'm sure with a slight tweak in technology could be recording these things and sending them to some server, and so you could get a lot of data on healthy hearts, and I would imagine some sort of a pattern recognition algorithm could figure out what it is that about certain frequencies that's good and bad. And
so I think this is happening now, that you can measure your electrocardiogram very cheaply at home. You could potentially put it on the internet. You can potentially, there are probably services where you could send your electrocardiogram, or there might be ways in which you can even monitor it at a distance, have people do that. I think that this is an area in which there's going to be an enormous expansion as time goes on, because, for example, supposing we had, I showed analyses of data from 24-hour Holter tapes in this talk today, but we don't know what the people were doing during those 24 hours, because the doctor says, please put on your thing, and then you'll take it off 24 hours later or 48 hours later. They don't really know exactly what was going on. When did the person eat? When did the person take drugs? And so forth. So to understand what's happening in those, we might have to understand when the person ate, when the person took drugs. People can easily keep those records if they really wanted to. People could keep a motion monitor at their wrist the same time they have the electrocardiogram. So I think that there's real potential in the future for having this sort of data being made available, and even made available by people, for people, being put out there for people in a community like this to come in and say, oh, here's how I'm going to discover something in these data sets. What do the cardiologists think? Should cardiologists know anything about nonlinear dynamics, or are they better off without knowing anything?
How about I answer a different question?
Oh, sure. What office are you running for?
Get a third question.
What about Republican nominee for president? We could.
I've established that I'll ask the questions anyway. So, well, certainly I think that you can, the heart is a complex nonlinear system, and to understand how such systems behave is to the benefit of anybody who wants to work with them, no question. One of the things that you have to realize regarding your question, Chris, that there's this unbelievably complex system with millions and millions of cells, and even if you were able to observe everything about that system at any one moment in time, you'd only be able to see what it's doing now, not necessarily what it's capable of doing should various conditions change. But we don't have anything like that kind of information. An EKG is like satellite photography of a chess game. You know, it's extremely little data to go on to draw conclusions. And even if we had more information, we are trying to predict what the heart is capable of doing in the future when, almost by definition, when they walk in to be studied, to be evaluated for the risk of sudden death, they're not doing it. They're behaving normally now, and you could say, well, what could you take them through their paces? Can we do something to see if they're vulnerable to it? And the answer is, to a certain extent, you can. You can look for the things that would predispose a patient to sudden cardiac death or these types of rhythms. But sometimes there are factors that you don't want to induce in the lab. So your heart would do fine today, but tomorrow if you had a lack of blood flow to the heart, you would do really poorly, even though tomorrow if I had lack of blood flow, I would do okay.
Right.
We could maybe uncover that in you by giving you lack of blood flow, but we're not allowed to do that right now. Right. So that's my only comment on trying to draw, I'm all for this sort of work, absolutely. But to try and draw conclusions, broad physiologic conclusions, simply from what is the overall cadence of the entire thing as viewed from the potential field at the surface of the body, that's a very small.
So I understand what you're saying, and I don't necessarily disagree with it, but I do. But
happen to, but you don't necessarily.
No. But we have the following situation. One of the things I do disagree with, you said so when people measure the electrocardiogram over 24 hours, for example, the Holter tape, there's an enormous amount of information in that. One of the problems is we do not know how to decode the information. Another one of the problems is that the people who have access to this data on a daily basis, for example, the cardiologists, you guys, are not necessarily looking at the information which is actually present there. So, for example, we can have two Holter tapes which will be read and will say, this person has 7,000 PVCs over a 24-hour period. They have 3 episodes of non-sustained ventricular tachycardia and so forth. Yet one of them might have very fixed coupling intervals, and one of them might have very variable coupling intervals. One of them may have lots of bigeminy, another one might have lots of trigeminy. Do those have any, what are the consequences of that? I look at some of these records where we get the, like just the list of numbers of normal beats between ectopic beats over 24 hours, and I see that there can be sequences of 50 numbers that go between 3 and several hundred, all of which are odd numbers that are occurring over a sequence of time in the middle of the day. I don't even have the differential diagnosis of what the possible mechanisms are that could be generating this sequence as part of my, I can't look in a book and say, okay, if you see this, then here are the possible mechanisms that could be generating it. If it's this mechanism or that mechanism, it might be dangerous. If it's this mechanism, then it's not dangerous. So there's lots of information which is going out the window now. Now, you might say, well, even if we understood that, we still wouldn't know what to do. We still wouldn't be able to assess the risk. And that's possibly true, but me as a basic scientist say, I just want to understand what's going on there, and I think it's something that we should be able to do.
Yeah, I mean, I totally agree with that. And as somebody who works as a clinician and sometimes as a would-be scientist, there's no question that you wear two different hats. When you're a scientist, you want the data so that you can analyze it in the ways you've described to hopefully uncover some fundamental principle. When you're a clinician, you want, as Jason would say, you're looking for actionable items, and that's all you're looking for. So I could say all sorts of things about the PVC. The EKG you showed, I could have waxed poetic for hours, but none of it bore on the question, is this patient at an increased risk of sudden death? So it just depends on why you're looking at these.
That's the reason why it was viewed as mental masturbation, because it doesn't tell the doctor more about what the doctor has to know and has to act on, and ain't going to write a PhD thesis on what's going on in this guy's heart, the way I can spend months trying to figure it out.
Well, predominantly as a clinician, it's worse than that, because if you look at a Holter, for example, and we identify a patient that has very low heart rate variability, we can say, well, yeah, this patient's at a higher risk for sudden cardiac death. Well, great. So on the other hand, we've also demonstrated that it's not predictive adequately to justify placing a defibrillator in that patient. So now we have this bit of information that gnaws at us that we can't act on. So the question is, how do we move to a step beyond that? The other aspect, specifically regarding sudden cardiac death, is that this discussion really has to do with where we have abnormal substrate. In fact, the vast majority of sudden cardiac death occurs where there's not abnormal substrate, but where the issue is a lesion, a coronary artery lesion, that's about to rupture, cause plaque, cause massive ischemia. And in that setting, the issue is really, can you detect ischemia that's relevant on a level that will lead to the sudden cardiac death, which actually is the vast majority of patients who are out there today dying as we speak.
Right. So on one of the slides, I specifically put in arrhythmic sudden cardiac death to distinguish it.
Well, that's an arrhythmic sudden cardiac death.
Well, except that the primary cause is a blockage of the artery. So I think that's it's a very good point.
Signal processing is probably incredibly important for that population, but you're asking a different question. You're trying to detect ischemia.
So, one of the issues also is the people who come to you are those who didn't die yet.
Right. Yeah, generally speaking, that's true. Neither of us are pathologists. So.
No. So the thing is, for example, there is enormous amount of interest on, for example, analysis of PVCs or analysis of monomorphic ventricular tachycardia, and whether program stimulation is dangerous or not dangerous, because patients that have those particular subsets of abnormalities might not die as frequently as those who have other abnormalities, which the first time it appears is fatal. So I think that there's a big selection bias in terms of, who people get. It just reinforces what you're saying. I'm not disagreeing. I agree with it.
What happened to the kid?
I don't know the answer. I think that. I haven't spoken to David Gordon in many, many years. I don't know, you guys probably don't know him, or Daniel Scagliotti. I think that he lived for, I think that the notion, if you look up in the books, generally parasystole is not considered as a high risk, as an arrhythmia with high risk. So, but...
And his syncope could have been from heart block.
because of the prior surgery and so forth.
And there was evidence of Hyperkingian disease.
Uh-huh.
So, I mean,
right.
so he could have had either. It's a beautiful example of where you're looking at something and you have two totally different things that could kill this kid.
Uh-huh. I don't know the answer to that question. Anyway, so this was great fun for me, great opportunity. I have to thank the cardiologists especially for having come. I know that they have lots of important things to be doing and so forth. So, and
Thank you very much,
thanks
Lee.
for the
That was
invitation.
truly
Thanks to the rest of you.
wonderful.